CEO and founder of Deuk Spine Institute, located here in Melbourne, Florida. And we're getting ready to broadcast live our second surgery for the day. Deuk Spine Institute broadcasts live every week surgeries that are performed here, of course with patient consent obtained. We don't identify who the patients are, but we talk to you about their condition and why they're having their surgery. Open for discussion, any topic related to healthcare or choral or Arias's racing profession. We stay away from politics, but I entertain questions generally related to spine or healthcare. This surgery we're about to do is on a patient with 2 herniated discs in his neck. He has neck pain that's been chronic. He has pain going into his left arm, numbness, tingling, and weakness. The patient also had pain in the facet joints in the back of his neck. He's already had a left C5 to T1 RFA, radiofrequency ablation, done by Dr. Patel. Now we're going to be treating the 2 herniated discs, C5-6 and C6-7. During the surgery, I'll take questions. Feel free to type your question in the dialog box, and Sean will ask me the question, and I'll do my best to answer it for you. All right, we're doing right approach 5, 6, 6, 7, correct? Okay. Okay. I'm going to go ahead and gown, and we'll get started. Our patient is asleep. For the lumbar Deuk Laser Disc Repair endoscopic surgery, our patients are receiving an IV sedation with what's MAC. MAC stands for monitored anesthetic care. Basically, the anesthesiologist monitors their breathing, their cardiovascular status, and their level of sedation. For this surgery, our patient is completely asleep, with a tube down into the trachea on a ventilator, completely paralyzed chemically. What is this, Luis? Nothing you did, right?
Huh?
That?
What is what?
That? Never mind. Watch the drape here. All right, are we relaxed completely? Okay. Thank you for doing that. I need a, well, I guess an AP is okay shot. Then a lateral.
Yes. Make sure it's not exposed to this, the fluid.
Quickly, Jordan. This is really supposed to start in a lateral view. I've told you that before. Table up. Move north, Jordan. It's too much on the table. I don't know why you're going up so high. You guys just want to challenge me today. Jordan, my fingers are killing me. Would you hurry up and get the shot, please? No, the table's up too high. Lower the table. Go north, please. Ah, Jordan. All right. Tell you what, why don't you figure out how to get the x-ray right in the lateral view, and then we'll get back to doing the surgery, okay? This patient has 0 twitches, correct? I would drop the table. Wow. I need you to write some notes for me. I need to talk to Dr. DeMola about post-op pain medication. Luis and Monica. Let me know when you guys are ready. All right, we need a shoulder pull. So we got 2, 3, 4. We need to be able to see 5, 6. So we need a shoulder pull. Who's got the shoulders? Can you give me some inline traction before you pull the shoulders? Yep. Doc, I'll need some inline traction. Alrighty. And shot. I don't know. Whose hand is that? Yeah, you need to be further up. Not on the spine, but on the head. Try it again. Alright, we need to see further south. 2, 3, 4.
Are you pulling, Mike?
Let's go. 2, 3. I need to see. I can't see anything there, Jordan. Hurry up. Lateral view. I need you to help me find that, Jordan. 2, 3, 4, 5, 6. All right, shot. 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 Give me an AP. Don't look over his shoulders.
You want a coconut or no?
Sure. Shot. So quick AP. Too far to the side. Shot. I can't see shit. Okay. What's the issue? Go back to a lateral view, Jordan. All right, so our problem here is the patient has some big shoulders and our x-ray technician is struggling to get us a good lateral view. So the big shoulders is not helping. Patients with wide shoulders, a lot of bone density, soft tissue density makes the pictures harder. Jordan, you're going to have to do a better job. I need to see that spine. So, how's our blood pressure? All right. All right, I need inline traction and a shoulder pull again. Luis, do your best to get the shoulder south.
It's kind of hard.
I know it's hard.
Yeah.
Who said it was easy, huh? Did I say it was easy? If I did, I misspoke. I'm sorry. Can we get that inline traction, please? Shot. Shot. All right. Shot. 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 I just can't. Are you pulling on the head?
Yeah, well it was.
Okay. Where's your irrigation? Get on the shoulders here, Luis. Shot. I need a head pull, shoulder pull.
26 range, please.
Shot. Should already have it, Luis. All right. So your x-ray screwed everything up. My hand is hurting too much to do it now. What did I tell you the last case for cervical? And why did you start with an AP if it's always lateral? Huh? I know it's your mistake, but the problem is when you make mistakes, it affects the surgery. We may have to cancel the surgery because I can't do it. Your mistake has led to potentially a cancellation of surgery. That's not good. All right. I need you to give me some inline traction. Move your hand. Pull on the shoulders. Let's see where we are. Shot. All right. Now, why can't you provide me that view? What level do we see down to?
2, 3, 4, 5, 6, 6, 7. I see the 6, 7.
Yeah, and you didn't show that, did you? I've got to have you guys doing your part, or I can't do my part. I can't do everything. Surgery is hard enough as it is for me to do if you guys do everything right. Okay? Shot. 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 Give me a quick AP. Shot. Hurry, hurry. I need to see where I'm at. Come on, come on. Don't let go of the shoulders, Luis. I never said let go of the shoulders, guys.
Get tired, I'm sorry.
I'm sorry you're tired, but it's too bad. You need to hold the position. You guys are killing me. Lateral. Fine. Let go. All right, relax for a minute. 2, 3, 4, 5, 6. Shot. All right, that's a discogram. You can see a tear. The dye's leaking out the back of the disc. Pull the shoulders. I need head and inline. Never mind. Actually, Jordan's got a nice picture finally shot. Shot. All right. You can see the herniation in the back of the disc there, sticking out into the foramen. Good control of the blood pressure. Injecting a little local. Make the skin incision. This is the only place basically in the world that you'll find this type of surgery done, folks. This is endoscopic, cervical, transdiscal, essentially annular debridement, which is the key cornerstone procedure of this surgery, and diskectomy, removing the herniation. Shot. I learned the basics over in South Korea and Germany from Korean and German doctors overseas. I was not, excuse me, I didn't tell you to do that. You don't see the separation here?
Yeah, that's what I'm ready with this.
You don't want to be putting things near that area, Luis. Pull it. Yeah, that's the wrong thing to do. The fact of the matter is, the right thing to do is to make sure that the dressing is wide and loose, not tight. You understand?
I understand.
That's what you do before I get here. All right, let's see. Shot. You want to make sure the guide wire doesn't advance onto the spinal cord. Shot. And you want to make sure you come down between the longest coli muscles, which I am, right on the anterior longitudinal ligament. Shot. Shot. Okay. I'm going to pull back the guide wire a little bit. Shot. Now this is the 5-6 disc. This is the top one of the two that we're going to be treating. Shot. Give me an AP, Coker. Perfect lateral. So that's a perfect positioning of the dilator, right in the midline. You can see the spinous process. Lateral shot. All right, now I'm going to advance this dilator into the disc. What do you think I'll need next, Luis? Shot. All right, now the dilator's in position. I could advance it just a little bit more. Shot. That's perfect. And we're going to bring the tubular retractor. So for those of you who have never seen a Deuk Laser Disc Repair done, go ahead and put the light on this. Anesthesia, if you don't mind putting the light on this. Just shining the light on here. That's perfect. The whole surgery is done through a 4mm tube. And it's all done endoscopically with a laser and a pituitary rongeur. So this is as opposed to open surgery that has an incision this big. You can see our tubular retractor is just 4mm. There'll be no fusion done. There's no need for a fusion. When you're not removing the entire disc to get to the piece in the back, pinching the nerve or spinal cord, you don't need to do a fusion. You don't need to do an artificial disc. So this technique, I was not the inventor of the transdiscal cervical diskectomy technique. I learned it from the South Koreans, but the South Koreans did not do an annular debridement. I'm the first person in the world to do that, and I found that by doing the annular debridement, we're able to get rid of neck pain. And by doing an annular debridement, you get rid of the headaches that these patients have. 2 out of 3 patients will have that headache. Shot? By doing the annular debridement, I can get rid of the arm symptoms of pain, numbness, tingling. Shot? So I want to make sure I'm not advancing the dilator because it'll go right into the spinal cord. And that would be bad. That would paralyze the patient, which we don't want. Did you already get it? So I'm going to advance this tubular retractor just to the very back of the disc, and then I'm going to remove the dilator, and we're going to do the entire surgery through that tiny little cut in his neck, okay? Which you saw earlier. All right. I'm going to put our fluid adapter on. All the equipment we use here at Deuk Spine is FDA approved. We don't use anything that is not FDA approved. Now take a look at the endoscopic rig. This is what we call the endoscopic rig, okay? It's in my hand. It's a camera. This is a high definition camera. It projects an image to the television monitor. It allows also you, the viewer, to watch through this cable. This, on the other hand, is the light cable. Let's turn the light on. It's a fiber optic light source, and it goes all the way down to the tip, and it's going to illuminate inside the disc. We also have the blue laser fiber and irrigation. Luis, the irrigation should always come in on the side opposite of you. Okay, over here. Why is this cable? Don't pull it. You're pulling unsterile into sterile. Can't do that. All right, let's go ahead and get started. That's right in my way. Let's bring the endoscopic tower closer so I can see what I'm doing. Huh? I want the lights down on the operative field. Get the fluoro out, please. Why are you doing things different, Jordan, than what we normally do?
Okay, perfect.
I'm sorry? Let's go. Let's go. Why are the wall monitors not working? We need to focus here. All right, you can see the laser fiber down there. You can see our first herniated fragment. The blue is the blue dye that I just put in. I'm going to go ahead and grab that fragment out. Now most people think a herniated disc comes out in one piece, but it doesn't. You'll get lucky once in a while and get a big piece that comes out. Most of the time the fragments are small. And that's about 95% of the time the fragments are small. We're overexposed. We need to turn down the brightness. So we're right here. You haven't turned it down. We're right in the base of the herniation. To the left, where that gold brown stuff is, that's the end plate of C5. And to the right is the end plate of C6. Sean, are you getting the endoscopic feed? There's a piece of herniation right there, folks. You see that? Are you getting the endoscopic feed?
No, we are not.
Sonny's working on it, but it's always the same thing every time, isn't it? It's the box in this room. All right, we just got a big herniation out. A nice chunk about the size of a pea. So what'd you guys do? Yeah, how'd you do that? I'm sorry, what was the problem? So what can we do, Beth, in the future to make sure that doesn't happen again? Huh? let me explain something to you.
Jordan just showed me what he did.
Failure and then solving it is okay. To me, failure is never okay. It needs to work properly from the very first moment. So, somebody forgot to switch the cables. How are we going to prevent that from happening again?
Check him before.
Who? The nurse needs to, right? That's your job. Okay? Can you make sure you do that? I don't want to have that problem again. All right, there's another fragment of herniation. The other one we got out was even bigger than that. Another piece of herniation coming out there. It's too bright, Jordan. This is the back of the herniation. And it's going out around the nerves back here. You can see a tear. The blue stuff is the base of the herniation. Some of the white stuff is scar tissue. Some of it's herniated disc. There's another fragment. What we're doing is we're getting reverse herniations. It's where the herniations come back into the disc from the epidural space, from the neuroforamen where they're hitting the nerve, irritating the nerve. So reverse herniations are good. We want them. We want to bring those herniations back and deliver them out through the tube. Anything that floats up towards the camera comes outside the tube that goes into our world where we are in the operating room. So I don't want the herniation down here by the nerve. And the glass thing you're seeing, the tube, that's your laser fiber. That's what delivers the energy that I'm using a foot pedal switch to activate the laser. And that delivers the energy to the tip of that laser fiber, which then vaporizes the herniation, which is what I'm working on right now. Now this is the annular tear and the herniation together simultaneously. I'm off in the left foramen. This is the arm that bothers the patient. So I always approach from the opposite side of the arm. I approach the same side of the leg. So if a patient has a lumbar herniation, I always go on the same side as the herniation, as the leg that's affected. But for the neck, I go on the opposite side. That's the right way to do it. Any questions from our audience?
We do have a viewer wondering what the recovery time is like for Deuk Laser Disc
I'm sorry?
Repair.
I couldn't hear.
We have a member of the audience wondering what the recovery time is like for
So
Deuk Laser
the
Disc
recovery
Repair.
time for this surgery is 1 hour. In 1 hour, the patient's discharged home. They cannot drive a car today because they've had propofol anesthesia. I mean, maybe later in the day if they're fully recovered, but not right away. But you can go back to a normal life basically today. Patients have a restriction. They cannot lift anything over 25 pounds. They cannot play contact sports for several weeks until we clear them. But other than that, you might see this patient out at dinner tonight at the restaurant. You might see them tomorrow at the shopping mall. These patients don't need a recovery. They're done. It's similar to having a pain management procedure. There's really not much recovery at all. It's just a matter of a few hours getting over the procedure. So it's immediate, go home, outpatient surgery. No hospital stay is even required. This patient, if they had gone anywhere else for surgery, they'd be having either a fusion or an artificial disc. And both of those surgeries usually require an inpatient stay and all the risk of having surgery done at a major hospital, whereas these surgeries can all be done outpatient. Deuk Laser Disc Repair, endoscopic. If you fly in from out of town, we have a lot of patients who travel from around the world. They come here for this surgery. If you fly in from out of town, you can go home the next day is what we usually typically recommend to patients. You can go home the same day if you're just wanting to get back home. We're very close to Orlando, so a lot of people will come in with their families, have their surgery done, spend a few days at Disney or Universal. Did you have another question there?
Yes, we do. We have a member of the audience asking, how far lateral off of the center of the epidural space do you usually debride?
How far lateral off the center do we usually go? So for cervicals that we're doing right now, we can go side to side, right to left foramen, literally all the way to the foramen. So there's no limitation but the uncinate process. Uncinate. That's an upward curving of the superior end plate of the vertebral body below, and that's really the only thing that's going to limit our lateral ability. But we use a what's called a windshield wiper technique, or windshield washer technique, and I just windshield wash or windshield wipe side to side. So I can decompress both foramens. I can treat annular tears on both sides of the disc. See just a little bit, there's another herniated fragment right there. I'm coaxing it out with my irrigation. So we use pressurized irrigation. The irrigation is cold. There's a huge fragment of herniation right there. See that? Stand by. So for those, I got to reach in with a long, skinny surgical instrument called the pituitary, and I got to try to grab it out. I don't think I got it. So I may have to go back in with the laser and scope and take a look. Yep, there it is. See it? It's just stuck in there. I'm trying to coax it out. Stand by. How are we doing on irrigation? just too big to get around it. Oh well. Could not reach it and get it out, so it's still there. I'm trying to wiggle it out. It's just such a big herniation fragment. I'm going to have to try to use a pulse wave. There we go. Take it. I think I need something by my feet because I'm standing in a puddle of water. There's another piece. So this patient would have had to have open neck surgery had he gone anywhere else. He'd have a cervical fusion, most likely, or an artificial disc these days, but artificial discs I don't recommend personally. I don't think they work very well. Their results are not as good as more traditional surgeries. And the endoscopic surgery really that you're seeing right now is the most advanced in the world. This surgery is called the Deuk Laser Disc Repair. It was developed here at Duke Spine Institute about 14 years ago after I met with neurosurgeons from overseas and learned the basic techniques, came back and basically made a lot of modifications to what was being done over in South Korea. Oh, that's another big piece of herniation. Whew, that is big. So this patient has several large fragments. We call them fragments of disc herniation. And normally we have patients with one or two fragments, maybe three, but this patient's fragments are big and he has multiple, as in probably 10 if I had to guess. And this one won't even fit out the tube. It's so big. But we're going to work on it, don't worry. I don't give up easily. And I haven't met a fragment that I couldn't get out. So a lot of times I just have to chop it up a little. Who is under the drape? Can you tell me why? If you want your blood pressure, just put a cuff on. Everything okay? Oh yeah, this is a huge herniation coming out. Wow, look at that. That's a big chunk. You want to turn the light on a second? Take a look here. You all see that piece that just came out?
Yes, we can.
All right, not the prettiest thing in the world, but that is a herniated fragment of disc. All right. You okay, Doc? All right, let's get over and help this poor doctor out. He's concerned that the tube for the blood pressure cuff is kinked. Can we check that, please?
Check what?
Twitches.
No, I'm not ready. Alright, ready for twitches? Nope.
Sean, any more questions for me?
There are none
See, a lot of
currently.
these herniations are central, more towards the middle, as I head back across to the other side.
Your blood pressure line should be pretty low. Yep.
Here's a piece. Now notice how smooth it is on the surface. It's smooth rather than irregular because it's been under the influence of inflammation. And inflammation has that effect. It basically destroys tissue by attacking it with inflammatory cells, which release chemicals that destroy things. Remember, your inflammatory system is part of your defense system of your body. So the inflammatory system is really like a part of the military branch. It comes in and just shoots everything up. And whatever happens to be there on the receiving end just gets annihilated. Typically what elicits the inflammation is a foreign invader, foreign body, bacteria, fungus, something that shouldn't be in your body. It triggers your inflammatory response. Is he completely relaxed? You said no twitches? All right. It's because I'm just struggling with mobilizing his disc, his bones. I didn't know if maybe he was clamping down. Here's the other foramen. Somebody was asking, how far side to side can you see, or can you go to the midline? Absolutely. We go right past the midline. We can decompress the center of the spine. We can decompress the sides. We can decompress the foramen, where the nerve roots are. All of this is being done arthroscopically or endoscopically. More fragments. Try to get these guys out. Any questions from our audience? Remember, if you're in the audience watching, you're allowed to ask questions. Feel free. We enjoy getting questions. Makes it more interesting for me.
We do have a question.
Sure.
We have a viewer who's wondering, with all that you're doing to the disc, will the material regenerate or will it be permanently decreased?
Yeah, great question. With what you're doing to the disc, will the material regenerate or is it permanently gone? So I'm not doing anything to the disc. I'm doing something to the disc herniation. Remember the herniation, you see that edge right there on your left and you see the edge on your right? That's the end of the disc. All this stuff is past the end. This stuff here shouldn't be here. It's already squeezed out of the disc and is pushing on the spinal cord and the nerves. So this is not taking away the normal disc. This is taking away the disc that has already left where it's supposed to be and is doing bad things. So I'm not taking anything normal away. I'm only removing the herniations. The herniations are out of place. They're not supposed to be here. Because the nerves and spinal cord are so close to the back of the disc, the herniations, when they leave the disc and squeeze out, they actually squeeze onto the nerves and spinal cord, which is bad. And that's why all these surgeries are done, to unpinch the nerves, unpinch the spinal cord. But remember what I told you earlier, if you don't have the endoscopic technology, then the only way you're going to fix this is by doing an open surgery. You're going to fillet open the neck and take the whole disc out just to get to the piece in the back. So the South Koreans who developed this technology, and Dr. Joe, and pretty much Dr. Joe, who's South Korean as well, they developed this technology so that you don't have to remove the actual disc in the front to get to the herniation in the back. You just go through it and leave it alone. That's the foramen right there. There's the nerve root. You see that? So it's totally decompressed. I've gotten rid of all the herniation. There's just a perforation in the ligament right there. You can see the dura mater. There's nothing pushing on the spinal cord anymore. So we're pretty much done with this one. Next, I'm going to try to get the next one, which is going to be even harder to get to. There's spinal cord right down there. This is just some thickening of the ligament from chronic inflammation from the herniation. This is almost gilding the lily. I'm not going to do that. Remember, we have a anti-gilding the lily philosophy here at Deuk Spine. We don't do things just because they look fun. We do them because they make a difference and help people get better. So there's the foramen over there. Here's a piece of herniation just outside the foramen within the disc. And once again, this foramen is clean. Just cleaning up these last few pieces of ligament. And we're pretty much done over here. I don't see any more fragments. Just some scarring there from chronic inflammation within the foramen. There's a little bone spur in the foramen right there. I just zapped it away. It's pushing on the nerve root. Maybe one last little piece there of really lateral. That looks good. We're done. Little bone spur there. Okay, so it's amazing what you can do. People say, oh, you can't get rid of bone spurs with a laser. That's not true. Those people who say that don't know because they don't use the laser. They're the ones who are jealous of the people like me that do use the laser. Okay? This is the future. If you don't learn this technology now as a surgeon, you're going to fall really far behind when it comes to spine. This is it. You can see the fibers of the posterior ligament right there. Pretty cool, huh? All right. Well, that was our... Hold on. That was our... I need pituitary. Let's turn the irrigation off. No, I need to go back in. We're done with the laser. I'm going to take the laser fiber back. Let's go back in and take a look. On. All right. Where, oh where? There you are. Pituitary. Light on here. Light on here. Come on.
Light, please.
Just that light.
This one, the other one, the other one.
Yeah, thank you. Hold that. Scope on.
On, please.
Huh?
We need some towels over here for wiping the floor.
Too much water. All right.
You good?
Yep. Let's do some medicine. So we're done with the first disc. And next we're going to attempt to get the next level, which is, believe it or not, harder than this one. All right, let's get some lights on. So to do that, we're going to have to take everything out of the first disc. I need the fluoro in. And we're going to try to move everything south. One disc. I'm going to need inline traction. We got good relaxation.
We're going to check that.
everybody ready? Well, hold on. So let's take a first fluoro shot and get everything lined up.
Yes, I need a fluoro.
All right. We're going to take this out. I need a fluoro shot. Okay, good. Shot. So we're taking the tube out. Okay. And a little pressure in case there's any bleeding. We sometimes have a little bit of venous bleeding. Shot. Okay.
I'm sorry, what?
Yeah, he wants you to step back so that he can check the blood pressure cuff or clean up the floor.
And then check the cuff again, right? It's got to be and ready for the cuff.
For what?
Alright, I'm ready. Got nothing.
All right, let me know when we can get back in. So we're going to attempt to move our instrument south to one more disc, C6-7. Right, guys, we're doing 5, 6, 6, 7.
Yes, sir.
And hopefully we'll be able to get that done. Let's see. All right, so I'm going to want pulling on the shoulder, Luis, like you did last time, and inline traction. You ready?
Let me.
It's our fluoro right there. Go ahead and pull. Give me some inline. Shot. Now remember, you should be squeezing in, Luis.
Yeah, that's what I'm doing.
Yeah, squeezing in, not so much pulling down. Shot. I need a little bit further south with you, Luis. All right, we're out. Shot. Relax for a second, Luis.
Thank you.
It's really not, honestly, it's pushing in rather than pulling down. All right. Let's get an AP shot real quick. Everybody just relax for a second. See where we are. Now, shot. All right, so we're just off the midline, which is fine. Lateral. Go ahead and get back in there. So we need inline traction. Do not lift him up, Luis. Just push the shoulders down. Luis, look at me. Push the shoulders in and down. There you go. Shot. See how much better that is?
Yes.
All right. It's not as hard either, is it? Shot. Almost there. There we go. Shot. All right. Give me an AP. Relax a little bit. Give me an AP. Get ready for a lateral. Give me an AP though first. Shot. All right, perfect. We're in the midline. Go back to a lateral. Let me have the mallet. Go ahead. Let's do one more lateral. Hopefully that will be it. And we'll be good to go. On the count of 3, 1, 2, 3. I need to see a little bit better. I need better than that. That's pretty good. Give me an AP again. Hopefully we're still in the midline. Line it up. That's perfect. Give me a really good AP though. Just give me your best. That's pretty close. I don't think you're far off at all. Just see if you can do a tad bit better. That's perfect. I love it. All right, lateral. We got lucky. They say it's better to be lucky than good, right, Doc?
Absolutely.
All right, I need one more everybody's effort, and then we'll be done. What's that fiber? And shot. I need inline. That's pretty good, actually. Shot. All right. Luis, I thought you were getting stronger. Let's pull the fiber out. We're going to need to redo the end, I think. Is it good? Watch the cable. Watch the cable. I don't want it down there. I don't want it down there. All right, I need the dye.
Yeah, it's good. Still.
It's okay?
Yeah.
All right, we'll do our discogram. Hopefully. I need the pipe cleaner. Watch it. So we've successfully advanced the dilator to the next disc, and I'm happy with our AP and lateral views. Now I'm going to do our discogram. These are not evocative discograms. These are just for injecting the dye into the disc space so I can perform the surgery properly. Is that my shot right there? Let's give one more pull. I'll do the left shoulder, you do the right.
Yes, sir.
And shot. Shot. Your hand is up too far. Shot. That looks good. Look at the dye coming out of the back. You see that? So 2, 3, 4, 5, 6, 7. Perfect. All right, that's good. I like it. We're right in the herniation. I was kind of surprised, given the amount of bone spurs this patient has, that he actually had so much what we call soft disc herniation. And his discs are pretty well preserved. So it's actually a very good choice for this patient in terms of the type of surgery to have for his herniated discs. I'll need you to stay there for just a moment. I feel like I'm on the anterior disc now. So I'll need one more shoulder pull and neck pull. The reason why we have to pull on the neck and shoulders, folks, is we won't be able to see what we're doing without it. All right, Luis, give it your best. Pushing in and go. All right. Shot. Yeah. Shot. 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 All right, do you all see the tube go down? Huh? That's good. Do you see it? You got good eyes? All right, so, huh? Yeah, me too. All right, let's get the fluoro out, please. So at this point, we've advanced this little tube, this little metal straw that we're doing the entire surgery through. We've advanced the tip of it to the back of the disc, right where the herniation goes out. And now we're going to find that herniation, zap it away with the laser, and clean up the tear in the annulus fibrosus that allowed the herniation to occur in the first place. That annular tear is the source of all the problems. So it's causing his neck pain, his headaches, and his arm symptoms. The herniation is part of that problem because it elicits an inflammatory response within the annular tear. And that inflammatory response is what causes all the discomfort. We clean up the tear through a debridement. And of course, the Deuk Laser Disc Repair, what you're watching right now, is the only surgery in the world that does a debridement, an annular debridement. Yeah, we need to rescore this.
So I need a stripper. Yeah.
I told you. All right. So that blue stuff is the dye that I injected into the disc in order to be able to stain the nucleus pulposus that's degenerating. So degenerating nucleus pulposus can be stained to help me identify it. By identifying it, I can more accurately remove the herniation. Light here on. Let's go, light here on. Light here on. That's fun. We're just putting the laser back in. There's the targeting beam. Why is the targeting beam up so high? I guess it's okay.
You want it down?
No, it's fine. All right, so once again, we're going to get in and remove the disc material.
We have a question.
Yes.
We have a viewer who says, I had laser surgery 6 years ago at the Laser Spine Institute in Tampa, and my pain is back in my right arm. MRI shows 2 bulging discs, and the tear is back. Why should I give laser another try?
All right, great question. So one of our viewers is saying, you know, I had laser spine surgery 2 years ago or 6 years ago. Sorry, 6 years ago on my neck. Look at that herniation. And the symptoms have come back. And should I give laser spine surgery another shot? Should I not? So this is a great question because there's a lot to talk about. First of all, the laser spine surgery you had at Laser Spine Institute is not the same surgery that's done at Deuk Spine Institute. They do a much older and less successful surgery there. What they do is they go through the back of the neck typically, and they drill a little hole in the back of the bone called a foraminotomy. And that is not a very good surgical technique, in my opinion. I don't do that surgery. I can do it. It's an older technique. It's been around for 70 years, but it doesn't work well. That's why I don't do it. So the fact that you have a recurrence of your symptoms doesn't surprise me, given the type of surgery you had done. You did not have a Deuk Laser Disc Repair. You had a foraminotomy at Laser Spine Institute in one of their locations. The foraminotomy also involves removing bone from your facet joint. That's a joint in the back of the spine there where you had your surgery. That's weakened your spine and it's caused it to wobble around a little bit. So I don't take any bone out from the spine when I do the Deuk Laser Disc Repair. Do you see us remove any bone? No. Plus we're going through the front of the neck, not the back. So it's a completely different surgery, much better surgery. There's no bone removed, there's no weakening of the spine. And the herniation that's causing problems, folks, is in the front. That's where I'm going. The Laser Spine Institute old surgery technique was through the back. It was an indirect decompression. The disc would push on the nerve from the front, but they would go in the back, and they would basically open the door in the back of the nerve, but it never really works that well because the herniation in the front is usually too big to effectively be treated through the back. If that makes sense. I hope it does. So should you consider laser surgery again? Absolutely. I think you should consider this surgery that you're watching. With this surgery, we could probably repair both of those herniations in one surgery. Look at that herniation right there. It's huge. And we can get you feeling a whole lot better. And the Deuk Laser Disc Repair has a 1%. That's 1 in 100 patients get another herniation at the same place I operated. And that's always because they do something they're not supposed to do. And what I mean by that is they'll lift something too heavy. They'll start doing some type of an activity too soon that they're not supposed to be doing. And that activity causes another herniation. So 1% of my patients get a second herniation after I'm done. And it can happen anywhere between a few days to a few months after surgery. Once you've waited a year after your surgery, your disc is completely healed from my surgery, the Deuk Laser Disc Repair. And then you can pretty much do anything you want. The disc is very strong. I don't know if I answered your question that you were hoping for, but the Laser Spine Institute, which is out of business, they're no longer in business. Their surgery on cervical disc herniations was not done the right way, and they had a lot of complications as a result of doing it that way. And a lot of times I was called to help explain their surgery and defend it. But it is definitely a standard technique So it's not below the standard. The problem is it just weakens the spine when you start taking bone out of the back. What am I sticking on?
Yeah,
That's just not right. All right, so we're on the left side here of the disc at C6-7. Fine. Yeah, another piece of herniation right there. What's that? Thank you. All right, we're almost done. I need about 10 minutes and we'll be done. Is our next patient ready? All right, good. So, as far as pain medications go, when people have a fusion surgery, it's really important they stay on the same pain medication they came in on after their fusion surgery until they're completely healed. It takes about 2 to 4 weeks, okay? Everybody knows that? That includes at the surgery center. Does that make sense? Nurses? Nurses? Beth, are you still a nurse? All right, good. Did you hear what I said? I said that patients that come in that are on pain meds, powerful pain meds, right, for their back or neck pain, and have a fusion surgery, they need to remain on those meds on the day of surgery. Okay, good. Just want to make sure you know that. Wow, another herniation. Look at the size of that thing. Incredible. So I'm going to have to go back in with the grabber. Has everybody had a chance to see the grabber I'm talking about? It's called the pituitary rongeur. Sean, you want to show our audience? This is the grabber. You see that?
Yes, we do.
All right. So I was not able to get it. I have to go back in and try again. You can see it right there. It's huge. It's misbehaving. Doesn't want to come out. And I'm zapping it with a laser. I'm just trying to show it who the boss is. Maybe with a little more coaxing it'll come out. Nope. No, it needs a little more coaxing. But obviously I can't go around it. It's too big. So I have to work with it to get it to come out. Sometimes if you just zap around that back edge, you can get it. It's maybe even needs to be freed up a little bit. And if it still doesn't want to come out, we'll go right through it and break it up into little pieces. The little pieces come out a lot easier than a big piece. But this is definitely a herniation. It was sticking out in the epidural space. It was up against the nerve root in the foramen and on the side of the spinal cord there. We call the lateral recess. Okay. Some of them behave and they just float right on out. They know when they're beaten. They're like, deliver us. And that's what we do, we deliver them. This is the neuroforamen once again. Okay. A little bit of herniation still here. The blue stuff. Huh? Annular tear, neuroforamen over here. The uncinate process is just at 1 o'clock. We're looking at the uncinate process just there from 1 to 3. This is all out in the foramen once again. Yeah. This is kind of an older part of the herniation right here. How we doing, Luis? Good?
Good, good, good. Yeah, it's I'm compressing here the chest.
Mm-hmm. There's a lot of herniation. It's more than I expected, to be honest with
Can
you.
you let people know that we're gonna flip the
10 minutes.
10 minutes.
Let's go to the other side. Careful with that fiber optic. It's just so many pieces of fragmentation. Usually it's an indication of severe trauma to the disc. Some type of flexion or compression injury. Mostly compression of the disc. For many years, this types of injuries went undiagnosed because on an x-ray things look okay. The problem is in the back of the disc. You can't see that with an x-ray. So people would suffer. And now with MRI technology, we can find these things. And as long as you're a student, you know what to look for, you can really help a lot of people who are suffering in pain needlessly. Most of the patients I get, they've been told, about half of them have been told there's nothing that can be done for your pain. And the other half are told they need a fusion surgery, more extensive surgery to fix their problem. That's because the surgeons don't know how to do endoscopic spine surgery. But for the ones that do, they don't have to do a fusion. You can do something less aggressive, less invasive. And that's what you're watching right now, endoscopic spine surgery. Spine surgery done through a tiny little incision and a tiny little tube. These are all bone spurs right there, zapping them away with a laser. Again, you're watching live surgery if you're watching today on, what is today, March 10th, 2020. I'm Dr. Ara Deukmedjian, CEO and founder of Deuk Spine Institute. You're watching a Deuk Laser Disc Repair. This is a endoscopic surgery done on the herniated disc. There's a herniated fragment right there. Look how good the view is, by the way. I mean, Luis, I don't know what you're doing with this scope, but this scope is nice. It's got great fiber optic, image. It almost looks like a rod lens type scope,
Yeah.
The quality is so clear. By the way, folks, this view you're seeing right now is better than the view that spine surgeons see with their eyes or with even a microscope. This is a more illuminated, magnified, better view of the back of the disc than about 99% of spine surgeons get. So you're seeing more than 99% of spine surgeons will see when they do this surgery on these disc herniations, because we're inside the disc and we're looking at things endoscopically with a camera. Hoo-ha. Still a fair amount of herniation there, huh? Incredible. You can see the tear in the annulus. It's the white thing, and the blue is the herniated disc material. Another piece right there. Where did that guy sneak off to? These are all just fragments. Remember I said earlier, we're going to have about 10 of them. I think that's about right. I haven't been counting them, but I'd say we're pretty close to 10, if we haven't already passed 10. Uh-huh. Well, just have it ready. I mean, I wouldn't spike it. We're really close to being done. I wouldn't spike it. Just have it ready. I'd say we have about 2 minutes left. Unless something weird happens and I come into a treasure trove of herniation. Huh? Well, you're helping us prevent that, aren't you? Yeah, you're doing a good job. I'd say 1 minute. Oh, you got nice flow in there. Any questions for us?
No more currently.
Huh?
There are no more at this time.
No questions? All right, I think we're done. Very good.
Lights on, please. Yes, please. You want to do it?
Yeah.
Thank you.
All right, we're done, folks. Why don't you take a look at what we've got here? And I want to show you how we did this surgery. This surgery was done through a 4mm incision. Yes, 4 millimeters. I'm going to show it all to you. Just let me a second. Let's move all these tubes out of the way. Grab that. Get this. All right. Move the light fiber optic. Can you aim that light down here, please? Just aim it right. Yeah, perfect. Right there. That's great. All right. Can you all see, folks? Look at this incision right here. 4 millimeters. The entire surgery was done through this tube. Look how tiny it is. Okay, this is the future of spine surgery for herniated discs. It's only here available at Duke Spine Institute, only place in the world. There are a few other places in the world, maybe a couple, 2 or 3, that does endoscopic in the cervical, but they don't do the Deuk Laser Disc Repair. I'm going to come answer questions for you in about 5 minutes, so start typing if you have a question, and I'll answer it for you, okay? Good job, everybody. Next surgery will be a lumbar Deuk Laser Disc Repair. Drop it. All right, Dr. Deukmedjian back with you with Sean. And we're like Batman and Robin, Superman and Wonder Boy. Who?
I didn't even know Superman had a sidekick.
Yeah, he did, Wonder Boy. Or Aquaman and Nemo. And we're here with you today just to chat because nobody's asking questions. So I got to find something to talk about. All right, we just finished a Deuk Laser Disc Repair. It's cervical, which is the neck. And, you know, what are these surgeries done for? They're done, people ask this question all the time. We do them for basically herniated discs that cause pain in the back or neck, pain, numbness, tingling, weakness down the arm or leg. And in the neck, you can also get headaches, and you can also get a pinched spinal cord because the spinal cord's in the neck, not the lower back. And when you get a pinched spinal cord, we call that myelopathy, if there's some damage to it. So myelopathic symptoms include balance difficulty, loss of control of your bladder, difficulty walking, difficulty writing, your hand coordination decreases. So there's quite a bit of things that can happen as a result of herniated discs. A lot of people don't know. They don't just cause pain. All right. Well, stick around. We're going to do another surgery soon, okay?